Hello everyone. First, I would like to thank the SCONA meeting committee for allowing us to present our work here. And for disclosure, we received funding from NIH, AIRWAY Medical, and Bayer Healthcare for some of the work presented here. So the topic of my talk today is nasal obstruction, what our nose are sensing. So complaints of nasal obstruction is a primary symptom that drive patients to seek medical treatment. It affects a wide population, around 13% of US populations or 30 million people. It can severely impact the quality of life of a patient. However, our understanding has been limited with objective measurements such as nasal resistance, endoscopic examinations, and acoustic rhinometry measurement often correlate poorly or inconsistently with the patient's subjective symptoms. So the traditional thinking from physician and patient is that the symptoms are due to physical obstruction in the nasal cavity, and simply removing that obstruction resolve the symptoms. However, our previous study showed that maybe the symptoms are caused not by obstruction directly. In this early published study, we asked a group of healthy subjects to breathe sample air briefly in three different boxes and then rate their nasal obstructions using the visual analog scale. So 0 for completely clear and 10 for completely blocked. So the nasal resistance is the same during these very brief sampling. The different boxes have different air source. So one is room air, one is dry air, same temperature but lower relative humidity, and one is cold air, lower temperature but similar relative humidity. We surprisingly found that the perception of nasal obstruction can be modulated by the change of air conditions. In dry air and cold air, the subject perceived significantly less obstructed. So this is intriguing, especially the dry air, since it has the same temperature with the room air as the room air. So we think potentially due to nasal heat loss or cooling as we breathe in air in the nose. We know that dry air can cause evaporative cooling. So if we compute the total nasal heat loss based on standard conditions, average conditions, we show that actually correlates very well with the nasal patencies or obstructions, with more heat loss resulting to less obstruction. So this leads us to hypothesize that we are sensing air cooling at the nasal mucosa during breathing at the index of sufficient nasal airflow. So if we don't have sufficient cooling, we feel obstructed. And this corroborated with previous evidence showing that menthol, which is a very common ingredient used in many food products and medications, chewing gums, nasal sprays. So menthol provides a sensation of decongestion and improved nasal airflow, but yet studies shown that it doesn't physically modify the nasal morphology. We think because menthol actually activates a trigeminal cool receptor, TRPM8, to make you feel you're breathing cooler air, presumably that resolve the symptoms. So today I'm going to show you some new studies we published in the last few years to really test this hypothesis. So the first study I'm going to show you is looking at nasal septal deviation. As shown on CT scan, so septal deviation is a deviated septum that may causes narrowing of the airway and obstructions. It is a very it's a very common problem. In US, about 43% of the outpatient surgeries involves a septoplasty or turbinate surgery to address the nasal septal deviations. But in our during our study, we actually find that not all nasal septal deviation NSD result in symptoms. A lot of the healthy control actually have it. So in here, I'm showing two CT scans. One is a patient, one is a completely healthy person. And I'll give you guys a few seconds to decide which one is a patient. Okay, here's the answer. Actually, this is actually healthy control, even though the deviated septum looks much more severe than the patient. And here are a couple more CT scans. There are only three patients among this CT scans. What are they? Okay, Here's the answer. These are the patients. And you can argue some of the healthy controls may have, septum deviate more severe than some of the patient has. And don't feel bad if you are, get it wrong, because we did the same with our surgeon partners. So we asked two surgeons, ENT surgeons, fellowship trained ENT surgeons, to rate blind review CT scans mixed with 36 healthy controls and 10 confirmed NS patient. And surprisingly, they identified all the patient. However, they falsely identified 66% of the healthy control as patient. So they're not doing any better than you did previously. And this is not because these two things are bad, right? So we actually did a follow-up survey study where we emailed CT scans to 61 board-certified otolaryngologists in US, and collectively they responded with about 60% sensitivity and 46% specificity. So they are not doing exactly much better than our surgeons in our department. And this is not also depend on level of trainings. We show that actually resident and fellows, these are medical trainees. They are performed similarly with their mentors, with the highest correlations between the groups. And it's not that these surgeons are really bad, because if we quantify the percent of deviations based on the corona image that's on the greatest deviation of every patient, and we quantified it by this percentage of deviations, and we can show that actually if we these are the healthy control that identified by our surgeons as patient, they have the similar degree of septal deviation as the symptomatic patients. So that's the reason why the surgeon can differentiate about them, because these healthy subjects have a significant deviations as much as the patients, whereas the non-deviate or healthy control without any deviations, of course, their deviation is much lower. So the questions now we try and answer with our follow-up and with our current research is, why are these asymptomatic nasal septal deviations have no symptoms, and more fundamentally, what is actually causing the symptoms in these patients with septal deviation? So we use the tools that everybody here is using. We build computation models based on CT scans, and we can simulate nasal airflow as well as many parameters from the modeling. And then the last step, we actually did some extensive measurement, including menthol lateralization thresholds. We think this could be assessment of the trigeminal sensitivity of these patients, as well as rhinometry measurement, which I will show you a bit later. So here first is, this is the confirmation of the patient symptoms. So this is two commonly used symptom surveys, nose score as well as SNOT-22, as can show that these patients are reporting significant symptoms. So they are really complaining, whereas healthy control, including the ones have significant septal deviation as much as patients, they do not report any symptoms as shown as the non-deviated healthy controls. And this is the measurement of nasal resistance by random manometry, as well as minimum cross-section area by acoustic rhinometry. Surprisingly, we didn't find any difference between these groups by even grouping them by deviate or non-deviate side. So they don't explain why the patients have. Next, we use our competition model to simulate the mucosal heat loss as the subject of breathing room air. And we divide it in different regions. By screening these anterior, middle, and inferior, by screening the variables, we found two variables that significantly different between the symptomatic patients as well as the healthy controls, including the one with significant deviations. They are anterior heat flux, average heat flux on the deviate side, which is anterior, as well as the inferior peak heat flux on the non-deviate side, so right here. So what this is indicative that maybe potentially these patients have significant different heat flux and cooling at the key regions than the healthy controls that result into their symptoms. And next, we show this is a result of menthol lighterization detection threshold. So I understand some of you may not know what they look like. So we have two bottles. We are subject to breathe simultaneously from two bottles. One is blank and one has some concentration of menthol. And then we ask the subject to pick which side has the menthol. It is based on the concept that odor cannot be lateralized. So if a subject can correctly detect which side has menthol, it is indication of he can sense the menthol trigeminal effect, which is cooling and some irritations. And each concentration bottles from lowest to highest is printed as once, and the test will end after 4 accept correct choices and also confident that they are making the correct choices. And we show here that the patient, symptomatic nasal septal deviation patients, have significantly lower or impaired worse menthol lateralization thresholds than both the healthy groups, the non-deviated healthy as well as the asymptomatic nasal septal deviation healthy groups. And also the worsening the level of lower menthol is actually comparable to other patient groups we have studied before, such as empty nose syndrome patients. And we can use menthol score alone to separate patient versus healthy control with about 70% sensitivity and 72% specificity, the purple line. And by using a heat flux variable alone, we'll achieve a similar result. I can show here about 50-97, and here is 80-69%. But if we combined menthol and the heat flux variable using a multivariate model, we can achieve a slightly better 70% sensitivity and 91% specificity. Anyway, all these results are significantly much better in performance than our surgeon did. So this really supports our hypothesis that the mechanisms of nasal septal deviation symptoms may be not due to obstruction alone. It may be due to distorted nasal airflow and mucosal cooling, and potentially exacerbated by poor nasal mucosal sensitivity. So when our nose receives a cooling signal, it needs also excellent sensitivity or neural senses to pick up this cooling. And if you lose either, that can contribute to the nasal obstruction symptoms. So, given these new information, what can we do about treatment of nasal obstruction? Can we design a better or more targeted treatment methodology? So next, I'm going to show you a second study we published to look at treatment of nasal valve obstruction using a new medical device. This device using radio frequency basically is heat energy, as can show in this cartoon. It's topically applied to the treatment area where the thermal energy will heat up the submucosal cartilage, cause lesion, and during the healing process, the cartilage and the submucosal tissue would reorganize and be stiffened. That's how it open up or stabilize the airway. The treatment is very brief and can be viewed as is minimum invasive. So this is in our office procedure. So at first we were quite suspicious of this this product or this device, but the person who's running the trials in the company, someone we know very well and very respectable, he reaffirmed us that they have done FDA trials and show the effectiveness, but they don't know why it works. So we agreed to do a small scale study. We look at 20 subjects with chronic obstructions, and these are the inclusion criteria. They have to have nasal valve as a primary contributor to their symptoms, and they can respond to some of temporary measurement to open up the nasal valve. And this is the endoscopic pictures of the, for example, one of the patients, pre-treatment, immediately after treatment. As you can see, this area seems to widen up after topically applied, radiofrequency energy. And this is 90 days post-treatment. Some of the changes potentially is gone. You can see, compared to the pre-treatment, it's difficult to tell if this airway is still opening up. And this is confirmed by looking at the CT scan, pre-treatment as well as 90 days post-treatment. As you can see that there is some difference, but it's not really a big or a substantial difference. And this is the computational fluid dynamic simulations of the airflow velocity. You can see the flow pattern doesn't change, definitely changes, and potentially related to treatment or not related to treatment. And that's why we try. That's what we try to find out. But this is the subjective symptom score pre and post treatment. As you can see that the patient do improve significantly 90 days post treatment. And this is the modeling or the CT scan analyzed result. If we calculate the airway cross-section area pre, as indicated in red, and blue in blue, post in blue, they almost overlap on top of each other with very little difference between pre and post treatment. And this is the affected area, treatment area, pre and post treatment airway area. You can see that there is a significant increase, but it's very small, only about 7% increase in average volume. This is an objective measurement of peak inspiratory nasal flow rate. Is usually used to measure nasal valve function, and you can see that pre and post treatment there's some increase, but not statistically significant. And this is the PNIF result. As you can show, it doesn't explain why the patients have such remarkable improvement, because there's no correlation with the patient's symptom score. And this is a correlation between a validation. This is PNIF correlates strongly with the nasal resistance simulated through the modeling. As you can see that this indicates that our measurement and simulation is accurate because they correlate well with each other, but both of them doesn't really explain why the patient's symptoms significant improvement. So we resort again to the simulation of nasal heat flux. Mucosal heat flux, as shown in this graph, actually the pre-treatment peak heat flux posterior to the nasal vestibular will correlate strongly to the pre-treatment nose score, and the increase in peak flux also correlate with the symptom score. So the higher or the more increase in nasal heat flux resulting in better symptoms as well as improvement. And as can show here, these two dots are these two patients example. So the top row is one patient that improves most dramatically, has 80 points increase. And you can see that this is pre and post. There is a very strong heat flux post treatment, and presumably that's helping the patient relieve symptoms. And this bottom row is one patient that has worsened the symptoms post treatment. As you can see that there is a strong peak heat flux pre-treatment, which is diminished or reduced post treatment. Presumably that's the reason that this patient doesn't improve. So as in summary, we show that minimum invasive radiofrequency treatment is potentially a successful clinical option to treat nasal valve dysfunction, even though it only produces a very minimum volume increase in the nasal valve region, but it may potentially have a profound effect on nasal symptoms, despite also little effect on the resistance as well as PNIF. This result corroborates our hypothesis that subjective relief of obstruction may be associated with improvement in regional nasal mucosal cooling beyond resistance and peak flow rate. And these key regions may be potential targets for future effective personalized treatment approaches. And finally, I would like to thank my team member as well as funding agency for our research. Thank you.